Hi, my name's Joe Bellick, and I'm the founding partner of the law offices of Bellick and Fox. We support the mesothelioma community by providing first quality legal representation to mesothelioma patients and their families. We're proud to support the Mesothelioma Applied Research Foundation so they can continue the work that they do every day on behalf of mesothelioma patients and their families.
At MRHFM, we exclusively help mesothelioma patients and their families. It's all we do.
This is why we are proud to sponsor the Mesothelioma Applied Research Foundation and its work to fund mesothelioma research and provide support services and education for patients and their families.
Hi, everybody. Thank you for joining us on this episode of Meso TV. Today, I am thrilled to introduce that we have Dr. Michael Offin with us from Memorial Sloan Kettering. And we're going to talk about chemotherapy and the different side effects that we see with the different chemotherapies. We're going to break it down a little bit today, kind of with each different chemotherapy. So, Dr. Offin, I'll have you go ahead and introduce yourself, who you are, and where you're from.
So hi, everyone. My name is Michael Offin. I'm a thoracic medical oncologist at Sloan Kettering in the city. I focus primarily with my colleagues in the mesothelioma program on helping patients and their families navigate a diagnosis of mesothelioma and its treatment.
Thank you. I'm going to start with having you give just a brief sort of overview of what the FDA-approved chemotherapy regimen is for mesothelioma and also how it's given. So what a cycle looks like with it.
Of course. I think an important thing to start with is today we're focusing on chemotherapy, but there are other therapies, including immunotherapies, which will not be discussed here. So that's also an important thing to know.
Yes.
In regards to the approved chemotherapy regimen for pleural or peritoneal mesothelioma, we use a regimen of two drugs, Cisplatin and Pemetrexed, also called Cisplatin and Alimta. These are both intravenous or IV drugs. This can be given through a peripheral IV, or if patients opt for a port, that can also be used. It's given once every 3 weeks, so that's a cycle. And in general, people may get anywhere from 4 to 6 cycles, depending on how they tolerate it and other clinical things we can discuss.
Thank you. I know a question that I get quite a bit is, if you have a patient that gets to those 4 or 6 cycles, what happens after that? What does that look like?
So it's a really important and good question. So it depends on several factors and what medications they're getting. So what I discussed, Cisplatin and Pemetrexed, the FDA-approved regimen, there is no approved what we call maintenance after the 4 to 6. So after completing 4 to 6 doses of those medications, you'd be getting interval scans for surveillance and being monitored very closely. But we do not routinely recommend continuing either of those drugs as maintenance because trials that looked into it did not show benefit and actually showed that there was increasing side effects the more we gave without a clear clinical benefit. I think we'll probably discuss a little later in this kind of meeting, but there is another drug which is not FDA approved, but it is in the guidelines as a recommended consideration called Avastin. That medication can be given as well with the chemotherapies. That can be continued as a maintenance. And like I said, we could discuss that later.
Yeah, thank you. Thanks. That was very good. My other question is, and something that I also get asked a lot of is, when you dose chemotherapy, how do they dose chemotherapy? And for somebody that needs a dose reduction, maybe because of tolerability, side effects, does that compromise the efficacy of the chemotherapy?
So it's really important. I mean, in general, chemotherapy by no means is a one size fits all. The medications chosen, the doses chosen is a very close collaboration between your doctor and you. We take into account many factors, underlying medical issues, blood counts, kidney function, things like that. The dose of the chemotherapy, each chemotherapy, when it was approved, is based off trials, and those trials kind of give us an idea of what the optimal range would be for the dosing. For instance, cisplatin, there's a math equation that takes into account several factors, including kidney weight and other things. Pemetrexed, similarly, we would take into account kidney function, but it's really based off of milligrams. It's the milligram dosing is based off the kind of surface area of the person, which takes into account several kind of measurements we would get. If the standard dose we felt was too much, let's say because somebody had a history of tenuous kidney issues or they had baseline problems with their blood counts, we can standard consider reducing that dose. And again, the dose reductions we use would be things that were scientifically proven in those trials to be reasonable doses. So we are not in the field where we would give people what we felt to be non-therapeutic dosing. We would reduce the dose to what we felt could still be beneficial but safer.
Perfect. Thank you so much. I'm going to start with Alimta, just because it's kind of one of the ones that we give a lot of different sort of pre-medications for, and often people don't understand that that's what they're taking them for. But patients are given a B12 injection, started on one. They also do a steroid prep and a folic acid supplement. Can you sort of explain why we give those different things?
So I think it's important to say chemotherapy has come a long way, and a lot of that also has to do with our preventative medications, things we give prophylactically so people can tolerate it better and have better quality of life on treatment. B12 and folic acid, which again are pretty, standard vitamin supplements, you may be able to get certain formulations over the counter. These are given at much higher doses. For this treatment, the B12 is an injection given usually by our chemotherapy nurse. Folic acid is a prescription strength version. We usually prescribe it to make sure we know exactly what's in the pill. These are actually there to help prevent blood count toxicity from the Alimta, and it helps people tolerate it better. And importantly, studies showed that by supplementing it, a person with these medications, it did not change the effectiveness of Alimta, but made people tolerate it better. So it was kind of a win-win to just give these relatively simple to use vitamins and make the treatment easier. Decadron, which is a steroid, similar kind of like a sister drug to prednisone. We give it for several reasons. It can really help a lot with nausea associated with the chemotherapy. It's also nice because a lot of people may experience a bit of kind of like a little extra energy around the time of chemo, which is nice. So as the chemo kind of has the anxiety provoking nature of getting it and you're worried about fatigue, there's usually a few days where you have that extra boost of the steroid in you, helps it with the nausea. Can also help sometimes with swelling that can occur with the Alimta. So overall, it's pretty standard. Your doctor would kind of discuss the exact use of the steroids. Sometimes we give it for the day you get treatment a few days after, and other times if people are experiencing a bit more nausea, we can actually give a longer, what we call delayed regimen, which is a bit more of a taper. So again, none of this is one size fits all. So it's always important to talk to your doctor about if you have symptoms.
And what are the sort of specific side effects that we see related to the Pemetrexed or the Alimta?
Yeah, so in general, Pemetrexed is a chemotherapy. Side effects of it could include, but are not limited to, things such as lowering of the blood counts. So anemia, which is lowering of the red blood cells, could cause fatigue. Lowering of the white blood cells can increase risk of infection. So we always say if anybody's on this type of chemotherapy and has a fever greater than 100.3, to always err on the side of giving the doctor a call. Lowering of the platelets is possible, so that can increase the risk of bleeding. Otherwise, things such as swelling in the legs, rash is possible, nausea or vomiting, diarrhea or constipation. Again, the hope is these would be tolerable. So if people are experiencing this, this should not be something where you just, grit and bear it. You should be calling the doctor to let them know. And there's other medications we could always try to help. And if needed, reduce the dose.
Yeah, we have much better options nowadays. I quite often tell people, don't try to stick it out. There are things that can be tried and different medications that can be used. I'm going to move on to cisplatin now. So, it kind of carries a lot of its own set of side effects. So I wanted to talk specifically about what some of those are, especially sort of like the hearing issues and those types of things, if you can describe that for
Yeah,
us.
so of course. So as I stated before, cisplatin and Alimta is what's approved. There's also a sister to cisplatin called carboplatin, which we can talk a little bit about as well. Cisplatin in particular carries with it several different issues. One is actually a bit more of patient experience. It's a long treatment day, so that's important to always talk with the person about. The medication itself is given, but then there's a lot of fluid that has to be given, and certain medicines are given to help people pass an adequate amount of urine so we can flush the kidneys, because cisplatin can be actually pretty toxic on the kidneys if we're not careful. Hearing difficulties with cisplatin are possible and can be cumulative. So whenever I meet a person, I always ask if they have any hearing problems to begin with. If they do, it may be a reason to try the sister drug carbo as opposed to the cis. If people come in and they have like mild ringing in the ears or they're not really sure, I always err on the side if there's, time to get it done. We do an audiology exam to begin with just to make sure we're not missing anything. And at the first sign of anybody noticing like mild ringing in the ears, or a lot of the time they may say like high pitched hearing loss. So like I wouldn't want to give this to somebody who made their living as a piano tuner or a singer per se, if that was very important. But at that first sign, I would always err on the side of getting an audiology consult, make sure we listen wisely to what they say. And at the first sign of any hearing changes, we would switch to carbo.
Okay. And what about, I know a lot of people complain also of like the neuropathy side effects.
Yeah.
What are some things that we can do for that, or that they can do for that, or that you recommend?
Yeah, so with cis and other medications, neuropathy, which is kind of accumulating damage to the nerve endings, can occur. That can happen in the hands, feet, basically anywhere in the body. Importantly, always mention it to your doctor at the first sign of noticing it, because nerves do not regenerate the way in which we would always like. And so damage, if it occurs, may not be always 100% reversible. So being dutiful in reporting it and making changes if needed is important. I always err on the side of people start having neurologic concerns. Things like gabapentin and medications can help with the symptoms, and then a very low threshold to get people from neurology involved. And again, if needed, reducing the dose or changing the medication to something that would be better tolerated.
Thank you. As far as carboplatin goes, which is the sister drug to cisplatin, do you feel like you see anything different with that drug, or maybe some lesser things or some differences from cisplatin?
I would say they're related drugs in the way they work. They have different side effect concerns. So they can both cause hearing loss concerns, but cis tends to be the more concerning of the two. So again, if somebody came in with baseline hearing issues, I may err on the side of carbo to protect the remaining hearing. Carboplatin can be a bit harder on the blood counts, so we have to be very careful with that. So if a person were to come in with, let's say, a baseline anemia and everything else was okay, maybe that's a reason to try cis. They can both be problematic to the kidneys. I would say, if I had to choose and somebody had really bad kidneys to begin with, carbo may be easier if they're able to tolerate it, but it really depends. They can both cause nerve issues. I'd say cis more than carbo, but we always have to be cognizant that both can do it. And in general, they both, again, can cause nausea, vomiting, diarrhea, or constipation, which hopefully can be dutifully managed by the doctors on the team.
As far as carboplatin goes, I know a lot of what we know is that it kind of works a little bit differently with an anaphylactic reaction, and when people tend to get more infusions, they become more acutely to the point where they could have a hypersensitivity reaction. So what does a hypersensitivity reaction look like to something like carboplatin? And when do you feel it is necessary to change the treatment?
So in general, a hypersensitivity reaction can occur to any drug at any time. It's always important to say it's based on the person. With carbo, what I would say is that with the more doses you get, your body may become sensitized to it. And if you get many, many doses, it's possible that the body eventually can have an allergic type reaction. So wheezing, shortness of breath, rash, low blood pressure, things that could require things like epinephrine and acute management by the doctors and nursing team there. So it's important. You get chemotherapy in a chemotherapy suite surrounded by people with the proper training for any instance, including hypersensitivity reactions. And so there's an algorithm they will follow, and the proper people can get there quickly to help try to reverse that acute event. If somebody had a hypersensitivity reaction, again, we would give them things that would try to quiet that allergic type reaction in the body. And then we would do things that, depending on the severity of it, we would either try to re-challenge with the drug at a lower dose slowly. We have an allergy and immunology team here, as do other institutions as well. They can help kind of navigate that. Many times we give higher doses of steroids and anti-allergy type medications. And in that circumstance where the severity of the reaction was too severe, or the patient kind of made the shared decision with the doctor that they didn't want to try it again, it would really depend on where they are in their treatment course if they would then pause and surveil, or if another medication would be needed.
Okay. And for something like carboplatin, I know that you can use this on other drugs too, but I have had patients that have gone through like a desensitization protocol. Can you sort of describe a little bit like what that is,
Yeah.
and when would you use it?
So again, I would say, like, in collaboration with an allergy immunologist, we definitely have that option. It tends to be kind of exposing a person to small and very methodically planned out doses of a medication, carbo or anything, and for that matter, to try to help the body reacclimate to it slowly over time. It's almost akin to what I tell my patients is like if you have a child who has a peanut allergy, you can introduce very small amounts controlled over a period of time. Sometimes that person will be able to then have peanuts after all, and other times they may have a reaction that has to stop, but it's done in a very controlled setting.
Thank you. I'm going to move forward a little bit. You talked a little bit about Avastin, and I wanted to talk about the different side effects with Avastin because it is a much different drug. So how does it work, which sort of leads to why we see the side effects that we see?
Yes. So Avastin, which is also called bevacizumab, is a monoclonal antibody. So it's an antibody that was manufactured to try to attack the way blood vessels are formed, something called a VEGF inhibitor. What this does is it tries to starve new blood vessels in the tumor, starve the tumor of blood flow and nutrients. The side effects of the drug are it has effects on native blood vessels and native blood vessel formation. So things such as blood pressure can be altered so people can get high blood pressure or worsening of baseline high blood pressure. Bleeding, bruising, blood clots are also possible. So we always have to be very conscientious if people have a history of clotting or bleeding. Rarely, but something also important to say is if it affects the way blood vessels are formed and maintained, there are rare reports of people that can develop perforations or holes in the bowel. So I always say if you ever have any, fevers, abdominal pain, anything acute like that, you're obviously calling me anyway, but we would send you to that person to the hospital just to be made sure there was no problem in the belly. Oh, sorry, you go.
No, go right ahead.
I was gonna say, I guess just to speak to how the medication is given and the setting it's given in.
Yeah.
Bevacizumab is in the guidelines to be given with platinum, so either cis or carbo, and pemetrexed. So it's given again IV once every 3 weeks, so it's given at the same time. At the conclusion of the 4 to 6 doses of the chemotherapy, unlike the chemo, the antibody Avastin can actually be continued as maintenance every 3 weeks for as long as the person derives benefit and can tolerate it.
Perfect. Thank you. And I know one of the other side effects of Avastin is that it can decrease wound healing as well. So if somebody has had a fresh surgical site or a port placed, they do recommend waiting to give it for a period of time.
Correct. If there anyone that is recovering from a large surgical procedure, even dental work, we would want to be very conscientious of, again, because to heal, you need to make new blood vessels. And so we have to be very mindful about when we give the doses of those medications as it relates to any kind of surgical procedure.
And then I just wanted to touch base a little bit on sometimes Neulasta is given with these medications, which is a white blood cell stimulator. I just wanted to talk a little bit about when do you give Neulasta, and what are the side effects of Neulasta as well?
Of course. So Neulasta, also called GCSF, and it can be given a few different ways. It can be an injection given or it can actually be something called an on-pro device, which is a little kind of like a hockey puck, thicker than a patch, but something you go home with. The nurses would place into the chemo suite, and it administers that medicine at home. The medication itself kind of tells your bone marrow to make more white blood cells. It's kind of like a call to arms, a stimulant for the white blood cells. And the hope is that we can give that to prevent the blood cells from going too low and causing what's called neutropenia, which can be a higher risk of infection. Everybody's practice is a little different, but in general, the way we tend to practice is we give Neulasta when a patient has either a fever on chemo or they have proven low white counts 3 weeks later, like when you're going to give the next dose, but the blood counts just haven't gotten there yet, then we would add it. Some people may give it outright in the beginning, which is not necessarily wrong. It's just different practices. But again, it's given to those people that we think would help stave off the risk of fevers or prolonged low white count. Side effects of the medication can include bony pain, because again, the bone marrow is located in the long, big bones in the body. And if you're telling the bone marrow to make a lot of stuff, that can be painful. Some people need to take over-the-counter anti-inflammatory type medications. There's some literature out there on things like Claritin as well, which can be helpful. I'm a big proponent of it because it's pretty low risk, and some people do get real benefit out of using it around the time that you use the Neulasta. Another issue could be really elevated white count. So if people have a really robust response to it, so you may get blood work and it may have a really high white count. In general, that's not overly dangerous unless it gets severely high. You can see things in that setting like rashes, and the blood can get a bit thicker. But again, that's pretty rare. And then rarely the spleen can get very large, because the spleen is also a place where the body can store and help manufacture these white cells. So we always have to warn people, if you get abdominal pain at certain locations, there's always the risk the spleen could be swelling. So we just have to be very careful of that. But in general, the Neulasta is pretty well tolerated. And we like it because in the people that have had prior fevers or low counts, it prevents them from being in the hospital, helps us keep them on track with their dosing, keeps them at home.
Perfect. And with the Neulasta, it's given usually on day 2, or you put the Onpro on and it will give itself on day 2, usually
Correct.
like 24 hours after the chemotherapy. The way it works, so you can't use Neulasta with every regimen. And that's because I'll have you explain just a little bit, like it kicks in at what point in time?
Yeah, so in general, Neulasta is a medication that when given a few days later will start really revving up the white count. And we say it has it basically lasts for about 11 days in the system, which is good for regimens that are given every 3 weeks, sometimes every 2 weeks. But you wouldn't want to give it for a regimen that's given every week, because then you're bringing up the white counts and then you're giving chemo and kind of knocking it right back down. And it can actually cause lowering of the counts over time if you keep kind of telling the marrow to give it everything it's got and then immediately kick it while it's revving up. It can actually lead to prolonged low white counts. So in general, we give it, like you said, day 2 for the Neulasta. And I tend to give that mostly with my every 3-week regimen, sometimes every 2-week regimen. And another important thing to note is if a person is undergoing radiation therapy of any kind, it's important to collaborate with both the radiation doctor and the medical oncologist to make sure that Onpro still makes sense. Because again, that could also cause a lowering of the counts if given at the wrong time period.
Great, thank you so much. I wanted to talk a little bit about if we have a patient who has progressed through frontline chemotherapy and then also progressed through, now that we have immunotherapy, the immunotherapy as well. Some of the other chemotherapies that are used in the space of mesothelioma. So I'll have you talk a little bit about something like Gemzar. How often is Gemzar given, and what sort of side effects do we see from Gemzar when the patient goes on that?
Yeah, so Gemzar, also called gemcitabine, is another IV chemotherapy. This can be given sometimes by itself or in combinations with other drugs such as Ramucirumab, also called Crimza, or Vinorelbine, also called Navelbine. To focus on the gemcitabine itself, again, that's an IV medication that can be given through a peripheral IV or a port. Some of the medications like Vinorelbine ports can become a bit more necessary. So at around that time in a person's treatment history, a lot of the times we start discussing a port. It's given in general either weekly, so we could do like 3 weeks on, 1 week off, 2 weeks on, 1 week off, 1 week, 1 week off every other week. So it's nice because we have a lot of different options and ways to give it, and we kind of base that off of how robust is the person in front of us, what do we think they can tolerate and still have good quality of life. And then, if we give it 3 days, three times every 4 weeks, and it's too much, then maybe we try two. And if that's too much, we can do every other. So it allows us to kind of find the Goldilocks approach when we use the drug. Side effects of gemcitabine include, again, lowering of the blood counts, nausea, vomiting, diarrhea, constipation, always possible. Swelling in the legs or rash, that can be a bit cumulative with time. Rare, but important to also mention, it can cause a syndrome that can affect the kidneys and the blood counts. So we always have to be monitoring for that. Some people can get almost like a predictable flu-like fever type syndrome after gemcitabine. So I always say to my patients, we're giving you this medicine. If you have a fever greater than 100.3, you're still calling. And so we would still do an infection workup, make sure that there was nothing else. But if we exclude everything and it was the gemcitabine, sometimes we'll actually give like a little bit of steroids after to try to help mitigate that moving forward.
And if you give it with the RAM, with the other medication, how are you giving that then?
Yeah, so gemcitabine plus ramucirumab, also called Gemzar and Crimza, is a relatively recent development in our armamentarium. So that was based off of the trial called RAMES, which was given with gemcitabine given 2 weeks on, 1 week off, and the ramucirumab given 1 week every three. So you can give it as kind of like gem-ram, then gem, then off. But again, a lot of the time we do this based on the person sitting in front of us. And so you could give gem every 2 weeks with ram every two, or space it out if needed. It really has to do with the person sitting in front of you.
And the different side effects with the RAM, it does look a little bit more sort of like the Avastin, but I'll have you talk about
Yeah.
that a little bit.
Yes. So ramucirumab is another type of antibody that also inhibits the way blood vessels are made and work, similar to like the bevacizumab. It's a VEGF inhibitor, but a little different. Side effects would include similar concerns, including blood pressure, bleeding, bruising, blood clots. Depending over time, if you're giving a lot of the ramucirumab, we have seen a bit increased blood count toxicities in some people, so we have to be very mindful of that. And important to say, if you're giving a medical therapy that's a combination of drugs, like in this instance, gemcitabine and ramucirumab, if a person starts to have side effects, you can stop one, usually maybe hold the ramucirumab and still try to continue the gemcitabine. So you don't necessarily have to stop both. So it gives us a lot of options.
And I did just want to mention, just, for patients and stuff, the ramucirumab has not gotten an approval yet in the United States. So they do battle insurance companies sometimes if it is something that the physician feels like they want to give.
Yeah, that's 100% accurate. While there was a provocative trial and integration and consideration within guidelines, it has not yet met the level of an FDA approval.
And then after this, a lot of times they will move to a drug called Navelbine. And this is when we talk about putting a port in place. And why is that? That does have to do with one of the side effects.
So Navelbine, also called vinorelbine, is what we would call a vesicant. It's very caustic to the blood vessels. And so it's the kind of medication that when you give it, you want to be very careful and sure that the chance of it going into the wrong space, like if the IV came dislodged, you want to make sure it's going exactly where you're expecting it to go. So having a port is a central way to make sure it's delivered into a large major blood vessel and that the medication can't accidentally be put into the wrong area like the skin or soft tissue. Other side effects of vinorelbine, lowering of the blood counts. It can be hard to tolerate on the blood counts, especially a lot of the time when people are considering that medicine, they've already had other chemotherapies. So there's that cumulative concern. Neuropathy, nerve issues can also be an issue here. In my experience, constipation more so than diarrhea, but obviously either are possible. And then nausea and vomiting is also possible with the drug. It can be given by itself, or if the person has not previously had gemcitabine, can be given with it. And again, it really just has to depend on a discussion between the patient and their doctor.
And I know with one of the big side effects with Navelbine that we had seen before is sort of that anorexia. They don't really have an appetite. Nothing
Yeah.
really sounds appropriate or good. I just wanted to mention that because we do get a lot of folks who tell us that one. I'm glad that you mentioned cumulative. So are side effects of chemotherapy cumulative? And if they are, sort of which ones are?
So in general, the body, the bone marrow does not forget prior doses of drugs. So many side effects can be cumulative with time. So for instance, if a person gets a dose of chemotherapy and their blood counts are pretty good, the third, fourth, or fifth time around, we can't rest on our laurels. We're always checking the blood counts because we have to assume that with time, those counts may drift down. We've already kind of discussed that hypersensitivity concern. So that's something that risk accumulates with time as well. Numbness or tingling can accumulate with time on certain drugs. Hearing impairment can accumulate as well. So again, I'm always a big proponent of if you're starting to notice something, you're not bothering us by telling us early, because we always want to be really conscientious that maybe at the first sign of something, we don't have to make a change. But if we start to see the trajectory of it getting worse, we want to start working on that earlier than later.
And once you have a person that stops chemotherapy, they've either meant those 4 to 6 cycles or they're going to start on a new sort of therapy. How long do you feel like those side effects kind of linger and hang around?
It's a great question. It is very specific to the drug itself and the severity of the side effect and the side effect. So if, let's say, for instance, it's nausea and vomiting associated with a chemo, over the course of a week or two or so, I would expect that nausea to improve. If it were hearing loss or numbness, tingling, that may get better over the course of many, many weeks, months, or it may unfortunately not really go back to where it was. So it's very specific to the drug and that side effect of reference.
Yeah, absolutely. I feel like fatigue is also one that sort of hangs out there for quite a while, takes quite a while for people to get over
Yeah.
that one. Well, thank you so much for being with us today. I don't know if is there anything else that you wanted to say, or did I cover everything?
I think that covered it for the most part. I would just add that while we had mentioned at the beginning the FDA approval of Cisplatin and Pemetrexed, it by no means is stating that carboplatin and Pemetrexed is not a very reasonable and good alternative. And many patients do get carboplatin instead, and it's a very reasonable and effective approach. So I do have patients that come in and they ask, well, am I at detriment if you give me one versus the other? In reality, giving the person the medicine that's safer, that I can give them adequate dosing of, that's the right medicine to take.
Yeah, that's the better path to go than to risk giving the cisplatin. Absolutely.
Yeah.
Well, thank you so much. We appreciate you for being here today. That was wonderful. I'm sure that people have learned so much. A lot of the questions that I get have been answered today. So thank you for being with us.
No, pleasure for you guys to have me. Thank you so much.